10.
مفهوم.
طيب هو تقريبا شبه تم موضوع اللايف. اوكي جود.
للحاضرين بالله يعني يا ريت لو كل واحد يكتب بلده بس باش نعرفوا التوزيع الجغرافي.
So I'll take in English because many of them is not Arab. So Dr. Qudayh is asking if you don't mind to write your country. Where are you from? The audience.
توزيع جغرافي. ما شاء الله.
There is echo.
ما شاء الله.
Somewhere.
كولومبيا. ما شاء الله.
UK, Germany, Algeria. Alhamdulillah. Yes, so let me say hello to everybody and then inshallah you can share your screen. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Hello everybody. Good afternoon, good evening, not good night yet, wherever you are. And most welcome to this very distinguished session with the superstar international glaucoma pioneer who is taming the monsters, Dr. Tariq Shaarawy, with the team, Dr. Qudayh and Dr. Munir. I'd like to thank you very much for allocating some time, some of your very, very valuable and busy time to this session to teach us and teach the audience. And welcome everybody for being with us. So Dr. Tariq Shaarawy, of course, he is a renowned international figure in glaucoma. And of course, every one of you knows Dr. Tariq very well, especially that he participated in one of the lectures before. So I would like to leave the stage to Dr. Tariq to talk about the 40 rules in glaucoma. And thank you very much, Dr. Tariq, please.
Dr. Mazen, what a pleasure to be here again with you. The first session, I think, went brilliantly. This is the second one. It is the rules for glaucoma, 40, 41, 39. We're not going to count. But it is a sort of a lecture where I think I would like to pass on the essentials of glaucoma. What I think are the bare minimum that everybody practicing ophthalmology should know about glaucoma. And then, as you can see, while we're going with this lecture, we're going to go into a crescendo. We're going to increase the level of sophistication of what you need to know. And I hope by the end, you will be able to have a very good background and baseline of how to practice glaucoma in an effective way. I would like to start by paying tribute to Dr. Mazen. We have the Sinjab Academy. A lot of people can make academies, but not a lot of people are academies by themselves. And I think Dr. Mazen himself is an academy, and we are participating in an academy that he created, but really the amount of patience, of energy, of sheer dedication, this is unique, and it is not unique on a regional scale. It is not even an international scale. It is more of a universal scale. So, Dr. Mazen,
Thank you, Dr. Tariq.
all my respects, Dr. Mazen. I have learned and continue to learn from your dedication, and I have followed your career with a lot of respect and passion. And passion is the word for what we're going to discuss today. When we're talking about glaucoma, I would like to pass to you some of my passion for glaucoma. Some people spend years looking for their calling. Somehow glaucoma chose me at a very early stage of my career. I think by the second or third week of being a resident, for me, glaucoma was the only subspecialty that I wanted to adopt or be adopted by. Ever since I started working in glaucoma, I have been struggling, as you all are struggling, with what we call the 50% dilemma of glaucoma. 50% of cases of glaucoma worldwide are undetected. At least 50% are undetected. 50% of people who are being treated for glaucoma are in fact people that do not have glaucoma. They are either healthy or have something else, but have been unfortunately abused by being treated for glaucoma while they don't have it. 50% of people who go to see an ophthalmologist, they have an eye examination and leave, and 50% of those have, unfortunately, their diagnosis missed. So imagine somebody going to an ophthalmologist and goes out without being detected, which is, it's very sad. And 50% of people who really have glaucoma don't use their drops. So we give them drops, we prescribe drops, we think that we are brilliantly giving them something and they will kind of obey, but that rarely happens. 50% of people don't take their medication. What is the burden, the visual burden worldwide? We are talking about 285 million people that are visually impaired. This is catastrophic. 40 million people are bilaterally blind. 82% of them are above the age of 50, so very young, and 7 million people go blind every year. Now, if you look at the WHO distribution of the causes of blindness, you find, to our utter shame and disgrace, that 50% of people who are blinded because of cataract. Now, it has been calculated that 3 months of the world's military expenditure will eradicate all the cataract cases that are in the waiting list. 3 months. So if for 3 months the world decides to not buy or sell or manufacture weapons, we are able to eradicate cataract as a problem. 12% of cases are due to glaucoma, and unfortunately, glaucoma is an irreversible blindness. So glaucoma is the first cause for irreversible blindness. It is the second leading cause after cataract. We're talking about 125 million people and 9 million people that are bilaterally blinded because of glaucoma. The type of glaucoma makes a big difference. Primary angle closure cases become more blind than primary open angle glaucoma cases. So undetecting or missing to detect cases of angle closure glaucoma is again a crime against humanity. If somebody goes to an ophthalmic center, ophthalmic emergency unit, or an ophthalmic clinic, and the angle is not assessed, even with simple ways of assessing it, as I'm going to show in a minute, so missing an angle closure is in fact a terrible crime. One other thing that we have to bear in mind, that 2/3 of people who are blinded by glaucoma are women. Is it because women live longer? No, I really suspect that this is happening worldwide because women don't have the same kind of access to medical care as men do around the world, which is what a tragedy that women, the women with all their glory and beauty and how the amount of care they provide to humanity, are deprived of equal health care compared to men. If you try to detect glaucoma by screening with intraocular pressure, you're losing your time because you will only be able to detect 20% of cases. Any screening for glaucoma has to be done not just with pressure, but also with evaluating the optic nerve, with looking for history, family history, for looking for any other of relevant history, and all the risk factors, including vascular risk factors, including refraction as a risk factor in the form of myopias and hypermetropias. And thus, in industrial economies like the States, Europe, and Australia, only 50% of cases of glaucoma are undetected. So imagine if we're talking about Africa, the Middle East, parts of Asia, and South America, what is the percentage of undetected cases, which we suspect would be higher than 50%. So there is a riddle, there is a lock, and this lock needs us to try to detect the undetected. How do we detect the undetected? It's easy to say, let's do eye examination every 2 years after the age of 40. Most books say that, including my book on glaucoma. We say eye examination every 2 years after the age of 40. Well, with age comes wisdom, and with wisdom comes certain realizations that a statement like that is total rubbish. Who does actually a routine eye examination every 2 years? I mean, I personally don't get a routine eye examination every 2 years. I don't know about anybody from my family or from my friends or from my neighbors that goes methodologically and religiously every 2 years for a routine eye examination. People go when there's a problem. So even if we try to advocate that, it is, for me, is rather impractical. So what do we do? Well, we first of all don't miss the opportunity at the ophthalmologist's office. Intraocular pressure and fundus has to be well examined. Families of people who have glaucoma have to be invited for screening. And even anybody who has an odd refraction in the form of a high hypermetropia or myopia should be examined very well to see if this person has glaucoma or not. Emergency units in hospitals, in eye hospitals around the world, a patient has to be well examined to be able to detect if there is a glaucoma or not. Military conscription, technique, people get an eye examination, though unfortunately most of those people are young. Driver's license, and I think driving license is very important as an opportunity to try to catch those cases. And I don't think that the national budget will suffer significantly if we ask the doctors doing a certificate for driving license, not just to speak about visual field, not just to speak about the visual acuity, but also look for intraocular pressure and comment on the optic nerve. There are other opportunities. For example, in Egypt, as you might know, presidential nominees get an eye examination. Having said so, in our countries, we usually have a very small number of presidential nominees. So catching glaucoma among them is not going to solve the burden of glaucoma around the world. We have to think out of the box. Should we do eye examinations when we do identity cards, retirement plans, معاشات, food stamps, بطاقة تموين? I do not have a clear answer. Every country and every lobby, an ophthalmic lobby in our countries has to have the ophthalmologist as a backbone of this lobby, and the patients together, and together they have to lobby for regulations and laws, and getting organized, just like the international working force, international labor force. We need to be well organized to be able to lobby for a better ability to catch glaucoma cases. But you know that every now and then we can catch a disease by coincidence. But this is not what I'm asking of you today. I'm not asking of you to catch glaucoma by coincidence. I'm asking you to have a high index of suspicion to be able to catch the disease. We are not trained to find diseases by accident. We are trained to find diseases by purpose, and we are only going to do that if we are looking for them. How do we look for an angle closure? Well, first thing is first, do a good Van Herk test where you compare the antechamber depth with the peripheral thickness of the cornea to be able to see if there is a higher chance of angle closure. And a narrow angle as described with a Van Herk actually demands or merits a formal and good gonioscopy. And when you do a gonioscopy, look for the small signs. This is a double hump sign that you see in angle closure glaucoma, in a plateau iris syndrome. You are not going to see those except if you search for them, and then you will be able to find them. This is a case of pseudoexfoliation. We are working with a very narrow beam, focusing the narrow beam on the edge of the pupil. And as you can see, we are able to detect the central disc. But again, you are not going to find a pseudoexfoliation except if you look for it. And interestingly enough, pseudoexfoliation is, as you know, associated with a higher morbidity. It's a more dangerous disease than primary open-angle glaucoma, but it is also associated with higher mortality. So people who have PECs have also higher risk factors for cardiovascular diseases. So sometimes catching something like that, sending the patient to a cardiologist you might be saving somebody's life. So we are not doctors of eyes. We are doctors of people who have eye problems. And there is an enormous difference and distinction between those two types of doctors. Whenever we catch a glaucoma and diagnose a glaucoma, there's something called the window of opportunity. It is the time where you are asked to create a good baseline for what is IOP, for what is disc, for how is the visual field imaging and gonioscopy. And when it comes to intraocular pressure, it is mandatory before starting to give the medication to a patient. You are highly advised not to start prescribing a medication for a person that you detect as having glaucoma immediately. Why? Because you need to know how high the pressure gets. There's a big difference if the pressure, the highest point is 25 or 35. And it is also very big because when you start giving the medication, what if a patient is 25, you give a medication and he's 19? That is not a big dramatic reduction in intraocular pressure, and probably the patient will progress. But what if he's actually 35 and he went down from 35 to 19? Then you have really scored well, and there is a good potential for you stabilizing the problem for the patient. So diurnal tension curves are very important. After that, your job is to detect small minor changes. These are 3 photos of the Mona Lisa Afghan, or the Afghan Mona Lisa, a lady who has suffered civil war, and in the span of 16 years, aged from a young, beautiful girl to a lady that is quite older than that. This is the civil war, and glaucoma is the civil war in the eye, where the optic nerve, who usually ages gracefully, ages in a super fast speed to be associated with a damage that will affect visual ability of the patient. So the photo of the Afghani lady is easy to detect the changes, but look at this photo, same lady, same dress, a couple of decades difference. Here, the changes are more subtle. And what you need to master is catching the subtle differences in visual fields, in OCTs, in subjective interpretation of the patient, and obviously in optic discs. So needless to say, all patients will progress. Your job is to try to find how fast will they progress. Because how fast is the most important factor to increasing or decreasing risk of visual impairment. And thus, when you can determine how fast the patient will progress, you will be able to make the right treatment choices for your patient. Now, you know those graphs. Best case scenario, median scenario, and worst case scenario. A patient that is progressing so fast that he or she will get blind or get significant visual impairment during their lifetime. So pieces of the puzzle, intraocular pressure, disc, visual field imaging, and gonioscopy. We have to put everything together to be able to have an opinion about how bad is the disease and how fast is the patient progressing. Because together, those things would allow us to make a decision on how aggressive we will treat. Now, looking at the disc is an art form. And people look at the disc and say, CD ratio of 0.8, let's treat. Absolute rubbish. CD ratios don't matter at all in absence of knowing how big the disc is. You have to determine how big the disc to understand if the cupping that you're seeing is physiological or not. Somebody that has a CD ratio of 0.2 and the disc of less than 1 millimeter, this is a person who is probably glaucomatous. Somebody who has a CD ratio of 0.8 while his disc is 2.8, this is probably a physiological disc. So it is very important to make things easy for you. These are 3 discs, all physiological, only differ in size, and thus big cups happen in big discs and small cups happen in small discs. You know how to detect or measure the diameter of a disc, vertical and horizontal, obviously. And to make things a little bit more complicated, you have to understand that it depends on which kind of loop of lens that you're using to be able to know the magnification. Each loop comes with a different magnification. For me, a glaucomatologist should rely on a Super 66. The Super 66 has a magnification of 1:1 to whatever you measure. You don't have to multiply or subtract or divide by a factor to be able to get the real measurements. And this is a table that I find very interesting. Depending on the on your lens that you're using, you can divide the optic disc into small, middle, or large. This is a very interesting tool that you should have at least memorize the ratios that are related to the lens that you're using. I am somehow try to think of myself as avant-garde in some things, but very much a traditionalist in other. I'm very much traditionalist in believing in optic disc photography. Cheap, reliable. It is the tool not just of the poor, but also of the rich. It is a technology that will withstand the test of time. This is a disc. This is the same disc 4 years on. I really don't have to describe to you the changes. It jumps from the photos in front of your eye. So this is a patient that is progressing. Beautiful photography, and you can see it. Visual fields. First 2 visual fields that you do, you throw in the garbage bin. And I use a lot of those photos to explain to my patient what is a visual field. Because if you bring your patient every 3 to 6 months and ask him or her to do a visual field, which is a boring examination, and you think that the patients will be happy and will concentrate on doing that without understanding why they're doing that, then you are fooling yourself. And it is 10 times better that the patient will come to ask you, how is my visual field? This is 10 times better than asking you, how high is my intraocular pressure? Teach your patients to ask the right questions. This is a normal visual field. This is the same visual field, but with a simulation of a scotoma. And I use that to explain to my patients when they have to stop driving. And I will say, this is a normal visual field. And with your visual field, you will see the lady only when you hit her with the front of your car. Total waste of time as well to put visual fields on the front of you on the floor. Some of my patients have more than 40 years of visual field. This is I would never be able to look at 40 pages per eye and decide. And why would I do that? We have very decent software, as you can see, that will analyze if the visual field, sequentially over many decades. I always want my technician to be close to my patient, to be able to make sure that the patient is attentive as he or she is doing the medication. And when you are doing the analysis, especially for trend analysis, we want to know if there's a trend for progression or trend for stability. To do that, you have to be able to have, if possible, the software on your computer so that you can choose the test points and to be able to analyze them. For example, if you see here we have been choosing only a few, the last few, which show actually an improvement of the visual field. But if we take all the changes over all the examination, each blue point is an examination. So we take all of them and then we can see a trend for progression. So it makes a huge difference to be able to do your visual fields yourself, or at least analyze them yourself. There is this trend nowadays of ophthalmologists sending patients to imaging centers where another doctor will do the visual field and then send the report. What can this report be of benefit for you if this doctor doesn't know every incident in the natural history of this disease? How can the doctor help you if he doesn't know when did the patient have a trap? When did the patient have the lenses removed? When did the patient have a correct refraction? The clinically relevant information is with the treating doctor, not with a doctor that is sitting behind a machine. So when it comes to imaging, I rely on imaging on pre-perimetric glaucoma to confirm perimetric glaucoma. And I think that what I am seeing around the world is an enormous abuse of OCTs. Every time the patient is coming, we order an OCT. Sometimes even I see doctors ordering OCTs and then don't really looking at them. And if you look at them, what kind of clinical information are you getting out of them? OCTs are absolutely useful, but ask the right question to be able to make use of them. Don't just order them routinely. If you order them routinely, this is an enormous waste of your time and of the patient's financial resources. And make sure to be able to correlate structural damage with visual field. Because if the structure and function are not similar, then there might be another underlying cause that you might be missing. And that could be a cause that is fatal. So if you can see here, we are superimposing visual fields on the structural damage and seeing them perfectly superimposed. So this gives you a lot of confidence that the damage is happening actually because of glaucoma and not because of something else. Remember the floor effect. If the RNFL thickness drops below 50 or 40, then what you are measuring would be glial tissue and blood vessels. And at that point, OCTs are useless and visual fields again become king. We go back to the 50% slide, and I take a breather here and discuss with you a case because I think it's interesting to try to demonstrate cases. This is a gentleman, 78 years old, who has primary open-angle glaucoma with a family history of primary open-angle glaucoma, addressed for cataract operation. And you can see this is the optic disc. First thing that should hit you is this optic disc looks absolutely normal, but the patient has been treated for primary open-angle glaucoma. Okay, I'm not very happy with the diagnosis of primary open-angle, but there's definitely cataracts. So the patient who has been taking a fixed combination of latanoprost or timolol and seek 60% best corrected visual acuity, fundus is fine. So we decide to go for a cataract procedure, nothing, totally uneventful, took 11 minutes. We put a monofocal IOL, nothing out of the ordinary. And the patient comes on the first postoperative day with a drop of vision from 0.6 to 0.3. Well, a bit of inflammation, maybe, you know, blah, 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 blah. Let's wait a couple of weeks. It comes a couple of weeks later with a vision still 0.3. So we decide to do a capsulotomy because the posterior capsule looks a little bit turbid. We did a capsulotomy and then we asked him to come back in 1 week. And we find after 1 week that the vision has dropped to 0.1. So he was 0.6, went to 0.3 and 0.1. And you can see the fundus, it doesn't look very happy. There are all those hemorrhages. So we're not very happy about that. In a live session, in a physical meeting, I would be asking you the questions, but for the sake of time and in the hope that we can meet face-to-face soon enough, I will show you what we have done next. Did an OCT for the optic nerve, looked very decent. We then we did an OCT for a macula. It looked absolutely normal, so no macular edema whatsoever. The visual field did not look happy for the eye that we operated. There was some visual field defect. Where do we go from now? Well, we did angiography, nothing absolutely conclusive. So what's next? We decide on an MRI. And this is what we find with an MRI. It is obviously a nasty macroadenoma. So we sent him for a hormonal evaluation. We found that his prolactin level has hit the sky. And we sent him to an endocrinologist who put him on a medication called cabergoline, never heard of it, but it started to do the trick. So the patient, first of all, came back to say, well, since I took the medication, my morning erection came back. So that for us was already an indication that something is happening. And then, as you can see, slowly visual field improved to 100%. Visual field defects absolutely became non-existent, and the microadenoma was significantly smaller in size with the medication. So again, just to remind you, we are not doctors that treat eyes, we are doctors that treat patients who have eye problems. And speaking of eye problems and glaucoma, deciding on how aggressive you are going to be with the therapy depends on the degree of glaucoma damage, on life expectancy, on the level of untreated intraocular pressure and rapidity of progression. So people who have a rapidly progressing with a low intraocular pressure of untreated intraocular pressure, young people who have a longer life expectancy, and people who have a advanced glaucoma damage should have a target intraocular pressure that is significantly lower. So which medication should we start with? It has to be effective, safe, economic, and tolerated. And Mazen and I, when we were slightly younger, we are still young, but slightly younger than that, we actually saw the introduction of prostaglandins into the market. We are a generation that was treating patients with pilocarpine and beta blockers, and prostaglandins came, and it was the big thing. And now with the combination of all the medications that we have with carbonic anhydrase inhibitors as topical, you have tens of thousands of options of medications. Some of them obviously are generic and some of them are branded. Patati patata. At the end of the day, you actually have to make the effort to make the right choice for the medication for your patient. Now, people have a craze of let's give preservative-free eye drops, and I'm speaking in presence of a cornea specialist, so obviously I can't go against preservative-free, and I believe in preservative-free eye drops, but with some caveats. I don't give monodoses for people who are unable to use them. This is a lady who's 96 years old. She comes driving her own car. She lives alone, and her ability to use is impaired because of a little bit of arthritis in her hands, and she ended up in developing corneal abrasions. Not fun. So before prescribing something like a monodose that has a tip that can be sharp as a Swiss Army knife, make sure that you get the patient to test it in front of you. And with all those stories, horror stories that I have seen, I've actually was inspired by a colleague of mine in Bern in creating a consultation that is 100% run by nurses. So our nurses, I spent almost 2 years teaching everything that I know about glaucoma except surgery for my nurses. And now we have a nurses consultation. This nurses consultation is reimbursed by Swiss insurance. And as you can see, they spend time, they explain to patients how to use medications. They talk to them about their handicaps, about their problems, about their visual inability to do something, and the repercussion of this consultation on the life of our patient has been tremendous. Remember, when you start treating a patient, especially with a couple of drops, to make sure that the patient will keep an interval of 5 minutes between 2 drops. Otherwise, the second drop will chase the first, which is a total waste of time and waste of resources. And it is quite sad for the patients, actually, because they will be progressing, and you won't know why they will be progressing, and why is the patient doesn't have a good control, basically because he is putting 2 drops that are giving the efficacy of half a drop. Sad. SLT, is it same as ALT, or is it just the packaging? Well, there is the LIGHT study that speaks very much in favor of SLT as first-line therapy. I have a lot of patients where I give them the choice of going for SLT or medications, and I follow their desire. I take the time, I explain the pros and cons. A lot of people say, no, laser, I don't want anything in my eyes. And there's a lot of people that are aficionados of the word laser. So they say, laser, yes, please. So, it's how the patient reacts is a factor that you have to put into consideration, especially that the science is not absolutely clear. There's nothing against starting with SLT, and there's absolutely nothing against starting with a medication. So what counts here is the desire of the patient, not your opinion, and obviously not how much money you're going to make out of an SLT or prescribing medications. You are not going to escape this presentation or this lecture without me speaking about surgery. Surgery has been a passion for me for many, many years, since I was taught trabeculectomy by none other than Peter Watson many years ago, many decades ago. Too long to, too long for me even to try to give you a specific number. But when you look at all those types of medication, all those types of operations that are either CE marked or FDA approved, it is a mess. It's a mix. So let's try to classify this fruit salad according to something, and we will classify them according to the strategy that we are using to drop the pressure. So going into the subconjunctival space, or going into the normal outflow pathway, accessing the suprachoroidal space, or finally destroying the ciliary body and closing the tap. Each of those can be from inside the eye, as in ab interno, or outside of the eye, ab externo. Having said so, now you can see the 4 strategies. Under each of them, there's an ab externo or ab interno. And for example, ab interno approach has been the Zen implant. The new approach is the arrow or micro stent. And I give you a few pointers about glaucoma surgery. This is a speculum that I have designed maybe 15 years ago. I have zero financial interest in the speculum, for my utter dismay. And you can see that you can use an 8.0 vicryl. For a cornea specialist, Dr. Mazen, I think he would be happier that we are using an 8.0 instead of a 4.0 silk. So very, very respectful of the cornea, stabilizing the globe, giving you a wider space on which you can dissect. Second thing that you have to absolutely remember is to test the mobility of your conjunctiva before operating. You can see here, we anesthetize the surface, and I am meticulously trying to gather as much important as possible about what kind of conjunctiva that I am going to manage. Glaucoma surgeons are conjunctiva surgeons. Very important first step in any glaucoma surgery that I do, more or less, is to do hydrodissection. People speak of hydrodissection for phaco's, but hydrodissection for a glaucoma surgeon is just as important. Notice this forceps that I'm using to hold the conjunctiva. Criminal to use a colibri to touch the conjunctiva, or anything sharp that will tear the conjunctiva. Every micron of the conjunctiva is useful when you are going to operate, because you need the conjunctiva to close. So anything that you're going to do, the most beautiful operation that you do, and you end up not closing and covering it, well, good luck with that. Zen implant was very sexy when it was introduced. Ab interno, nice looking injector, an operation that takes a few minutes. A lot of us now have abandoned Zen implant because the amount of scarring after the Zen is horrific, and we have to do a revision or needlings for those cases. So many people now who are still putting the Zen are putting it ab externo, just like the micro stent. Here you're seeing a micro stent marking 3 millimeters from the limbus, then creating a pocket with a spear knife, as you can see, not perforating with that, just creating a pocket. From there on, we take a 25G and you perforate into the antechamber, all the way into the antechamber. Once we are in, we go out and start thread the implant in. Notice that the end of the implant is about maybe 7 millimeters away from the limbus. So the filtration is very far away from the limbus compared to a trabeculectomy or a deep sclerectomy. When it comes to tubes, I see a lot of hope with the pole glaucoma implant. Those implants are very similar to the Barveld, but they have a tube that is significantly narrower, which has probably an interesting effect when it comes to things like erosions. They are smaller tubes, and with things like endothelial cell loss. So when it comes to eroding the conjunctiva, this is a technique that I have described I guess 10 years ago. We can see we are creating a flap that is huge, 10 by 5, and it is hinged on its side. After that, we create a trench. So the technique I call the envelope and trench technique. I am too modest to call it after my name. I think people who say, you know, the X operation and the X, for me, it's a little bit pompous. I think we should be more modest than that. So the envelope and trench, we are creating a trench. This is the trench after we have created it. Then we go with the needle. I am always going for smaller needles rather than wider needles. I like to see a bit of resistance when the tube is going in, because this means that there will not be a lot of aqueous going around it. We are introducing, as you can see, the tube, and quite easily 2 10-0 nylons, and everybody lives happily ever after, if you can actually believe that. If you want to avoid in pseudophakic patients endothelial cell loss, you can opt for putting the tube behind the iris. The tube has to be significantly longer than what you are used to, because ideally you should be able to see it when you dilate the pupil, and you should see it tangential to the pupil rather than into the visual axis, for obvious reasons. If the tube is interfering with visual axis, then you might not allow the patient to see. Blebs. Well, you know, glaucoma surgeons look at their blebs and they are in awe of the beauty of blebs. You know, we have created a nice bleb. This for me is pathetic, because we take a topography of the eye that is, subhanallah, unbelievably beautiful and well created by the creator, and we end up actually destroying it with what we call blebs. Are all blebs born bad? No, not all blebs are born bad. You see here a decent bleb, shallow, relatively vascularized, and not too prominent. But a lot of blebs develop what we call a Bleph Dysthesia, which is a discomfort with the bleb. It happens in 20% of cases, Bleph Dysthesias. And you can try aggressive lubrication, non-steroidal, eye drops, bandage, contact lens. Good luck with that. They rarely work. So when it comes to blebs, there are 2 types of blebs that I find very important. The fat and big, the ugly and dangerous. Simple as that. So we start with fat and big. Fat and big are terrible, and they give a very uncomfortable life to your patients. Those are blebs that look like that. And your best friend will be the Palmberg sutures, 10-0 nylon, compress and compartmentalize the bleb to be able to improve. And you might opt for an autologous blood injection, as you can see here. In most of my patients, in the first post-operative days, patients feel much happier. So as you can see here, those they create a cheese wiring, and the bleb becomes smaller with time. I rarely lost pressure control. So we spoke about the big and fat. Now we speak about the ugly and dangerous. Ugly and dangerous blebs are even worse than the big and the fat. Why? Because they are actually can be a precursor for something like a blebitis or endophthalmitis. So don't ever accept a bleb like that. Those blebs have to be managed. This is a bleb associated with hypotony, and not really a lot of aqueous is coming out, but still it is not looking very well. So put a little bit of pressure, just a little bit of pressure on the globe, and you see all those coming out. So don't test a bleb without slight pressure on the globe. What do you do about a bleb like that? Well, you basically have to unroof it. I don't excise the whole bleb if I can. I try to just remove the superficial layer of conjunctiva on top of the bleb. The bleb is like a house. Take the roof and leave the house. You don't have to demolish the house because the roof is leaking. And then create a new roof. Simple as that. Here you can see we are using an 8-0 vicryl, round needle, using a decent forceps to close the conjunctiva, creating a purse string to be able to close the conjunctiva, healthy conjunctiva, on top of the bleb, as you can see here. And this is the bleb after the operation. Nothing is coming out. And again, this is another catastrophe. A patient that had 8 years ago an express implant, and you can see it is not leaking. It's almost a fountain coming. reminds you of a certain landmark in Geneva, the Jet d'eau, the famous fountain of Geneva. Aqueous is actually coming out madly from there. How to manage that? I do a hydrodissection to explore what is happening around the bleb, as you can see, and then I open to see really what is happening. There is a hole in the wall of the eye and the choroid is coming out. You can manage that with a tutoplast. I decided to do an autologous graft, so I created a scleral flap, turned it on its side, and used 2 10-0 nylons to close tightly on the hole. 10 times better to use the tissue from the body rather than using anything coming from outside, and putting mitomycin and pulling the conjunctiva again with the 8-0, as you can see here, making sure that we really close very well. Take your time with those cases, and they're fun. They're fun because they're not the everyday case. They're different from what you do all the time. This is a patient of mine that taught me something. He taught me that I absolutely have to listen to my patients with a lot of respect. He came to say that he hears his bleb, that the bleb is creating sounds, and he thinks that the bleb is trying to communicate with him. Well, looking at the patient, you can say, well, okay, I'll send you to a psychiatrist friend of mine to discuss with you about that you're talking bleb. But sometimes if you are old as me, and if you are compassionate, you give your patient the benefit of the doubt. So I went to a friend of mine who's a sound engineer. He created a studio for the eye, a special studio for the eye, and we started recording sounds coming from the eye and amplifying the sound. So here, for the very first time, probably for you, here's the sound of a bleb. So not to take too much of your time, it goes on and on and on. A patient is feeling this hammering in his eye every second of his life. A few Palmberg sutures, patient was happy, the sound went away. A month later, he came and said that now he feels lonely because the sound is no longer with him. And I easily advised him to get married. So back to all the new types of operations. Is there a light at the end of the tunnel? Maybe. You know, those new devices that you can see, this is the mini-ject. It's a device where we can put it in the suprachoroidal space. Would that help us reduce the pressure, knowing that these things are not associated with blebs? Those are blebless procedures, or even hybrid blebs. The micro shunt, as you can see here, has a bleb that is very far away, and it is shallow and it is decent, and patients are comfortable with that. So there is some light at the end of the tunnel, but those devices, mind you, can scar. This is an absolutely scarred micro shunt. You open on top and you see it completely buried in scar tissue. Nothing is coming out, and it is very gratifying and fun to be able to meticulously dissect the implant with a micro scissors, get it released, give it a second life. Our Indian friends would, at least some of them, will believe in reincarnation. This is a reincarnation of this tube once again. And you see by the end of the procedure, aqueous is freely coming out. A little bit of mitomycin. We put we close the conjunctiva and we give a second life to this. Those devices can be associated with problems. This is an eroding device. We basically took it out on the slit lamp, left behind the suprachoroidal cleft, had to take the patient to correct the suprachoroidal cleft again into the operating room. Nothing is straightforward, and things are more complex than you can ever imagine. Again, I speak to you about another case very rapidly. This is a patient that has a pressure that is high, as you can see, 32 with mild cataract. So, and the glaucoma is terrible, as you can see here. So we basically decide to operate the patient. The decision was, you can see here the OCTs, very, very sad looking discs. So we decide to simply go for combined phaco-deep sclerectomy in the right eye and then in the left eye. To cut a long story short, we do it in both eyes. In the left eye, pressure is 12, but then all of a sudden the patient comes with a drop of visual acuity. His actual refraction changed significantly from a -3 to +2, hypermetropic shift like you've never seen, choroidal folds in the macula, in the optic disc, and the pressure of 2 with hypotonic maculopathy. And the reason for the hypotony, again, this is supposed to be interactive, but to cut a long story short, it was not a microcidal. The trabecular-Descemet's membrane did not rupture. There was no overfiltering bleb. So what was the reason for that? Whenever you are in doubt, you dilate the eye. So we gave a little bit of tropy and we dilated the eye. You can see that there is a certain degree of phimosis of the anterior capsule. Doing a UBM shows a ciliary body that has been detached. So detached ciliary body means better access to the suprachoroidal space and less production of aqueous. So what do you do about that? The clever among you will answer, we do anterior capsulotomies. Simple anterior capsulotomy. 2 days later, ciliary body in its place, pressure is 14, vision that was 0.1 goes back to 100%. And here is the last slide. This is the Da Vinci robot. We have the Da Vinci robot in Geneva University. And you can see that we can actually use the Da Vinci robot for eye surgeries. It is being used, as you can see, in applying an amniotic membrane and amniotic membrane graft and suturing the amniotic membrane on the surface of the eye. They call it a robot. I call it a fancy PlayStation 6, perhaps. At the end of the day, there is a joystick. And though the instruments look more fancy, it's you, the surgeon, behind the device. With that, I thank you very much. And I think if Dr. Mazen allows, we might have a few minutes for questions. Thank you, Dr. Mazen.
Thank you very much, Dr. Tariq, for this fantastic and wonderful lecture, as usual. Very academic, direct to the point, and let's say it is fatty meal full of information. We need a lot of time, of course, to digest the information. So I will leave the stage now to Dr. Qudeh and Dr. Munir for the discussion.
Thank you very much, Dr. Tariq. This was very informative, and I personally have learned tremendously from this. Thank you very much. Yeah, if you can tell us more about the Paul implant.
Yeah, the Paul implant is a Singaporean technology. The brain work of Paul Chu, who is the head of the he's the head of the University Department of Ophthalmology in Singapore University. Brilliant gentleman and a very close and good friend of mine. For many years, I've been a visiting professor in his department. He actually looked at what is wrong with Barveldt and Ahmed and decided to do something as effective as the Barveldt, but with a smaller tube that would allow for less incidence of hypotony, and at the same time putting something smaller in the eye compared to a tube that is Ahmed or Barveldt. That, to be honest, let's speak seriously, this is a technology that has been there for what, 25 years now? I mean, what stays for 25 years as an implant in medicine? So what he has done is something that is quite interesting. He puts tutoplast to cover the plate to reduce the potential for hypotonies, and at the same time reduce fibrosis around the plate. Not everybody that is using the implant ties it. Some people tie the implant with absorbable implants. Some people will stent the implant. I have been using the implant the same way that Paul has described it, actually putting a tutoplast and not tying it or tying it very lightly, depending really on what kind of a case I'm managing.
Yeah. Is it valved or non-valved?
It's non-valved, non-valved. It is very similar in concept to a valve type.
My biggest concerns with tubes is not actually the hypotony that we get. That's manageable, but really the concern is the long-term effect on endothelium, you know, and the failed corneas. That is the biggest. So I agree with you.
Yeah. So Dr. Qadih, I share your concern. Maybe 15 years ago, I was totally engrossed with this idea that I started to publish a series of papers on how tubes affect endothelial cells. I remember the first study that we published, we looked prospectively at valves and endothelial cells. We used an HRT corneal module and we used an anti-segment OCT. When that was presented, a lot of people who put a lot of valves, like Keith Barton, who's a very good friend of mine, of course, were, you know, very dismissive that, yeah, this doesn't happen with us. But no, it does happen. If you put a tube in the eye, you have to have a good reason to put a tube. You don't put a tube because you just, you know, feel like it. Because yes, there will be endothelial cell loss prospective, and it will never stop. It will only stop when you bury the patient. But as long as the patient is living, he is paying with a specific currency that is called endothelial cells. So I totally agree with you.
Thank you. And I think your idea of putting the tube pars plana, whenever I can do that, I really go for that. You know,
I don't put it pars plana. I put it into the sulcus.
I meant sulcus. Sorry, yes, yeah, in front of the IOL. Yes,
exactly.
Yes.
Anything else to add, Dr. Qadih?
No, that's
okay.
Yeah,
first of all, thank you very much, Dr. Tariq. That was fascinating presentation as usual. The way you present and all the information is really, really extremely amazed actually. Thank you very much. I have few questions, if that's okay.
You can summarize and say that I'm the best thing after chocolate, but you know.
I think so, even before chocolate. Before chocolate.
Sorry, go ahead.
Yeah. First question, you mentioned about OCT. So sometimes you have these cases when you see significant deterioration on OCT, but the field is absolutely stable. And the patient is already on maximum medical treatment, possibly slightly elderly. So in these cases, I know that you don't need to go with the OCT, but in these cases, would you consider this just to possibly suggest the surgical option to the patient, or you still wait and observe till you have definite change in the field?
No, I wouldn't. I don't have to wait for definite visual field to progress. But as you know, Munir, it is very case by case. You know, there's no one fit all. So I need some more information. I need to capture progression with something that could be the OCT or visual field. I need to make sure that progression is happening because of glaucoma. There's not a central problem somewhere that is causing catastrophe or something else in the eye, because nowadays we are so subspecialized that I think the new generation will specialize into people with the right eye and people for the left eye. But it is really, really, really important to make sure that the progression is happening because of glaucoma and nothing else. And I look at the patient in general. Do I have the luxury to wait and see? Is it a patient that is young or old? Is the patient that has one single eye, or is he a good singer? Does he have a family history of blindness because of glaucoma? It's the sum of all that. And your decision is always better when you capture a bigger amount of information so that you have an informed decision rather than guesstimate. The sum of all those together can put you into a decision to operate or not. One of the factors has to be stability or instability of the OCT. Have I operated a lot of patients based on OCT damage? I can't say that it happened a lot in my career. It happened, but it didn't happen a lot that I saw a massive deterioration of OCT and absolute stability of visual field. And to be honest with you, if I see OCT progressing and if I see optic disc changes, morphological changes that I can capture with my own eye, even if the visual field is good. In a young patient, for example, that for me would be an indication to operate. I'm sorry, it's a very long answer, but you know, glaucoma is very complex, that short answers don't work in our field.
No, completely agree. The other thing is, are there any instances or examples where you give up on the patient? Like, let's say if the patient is 85 plus years old with the deterioration in the field and possibly poor general health, but you think, okay, there's nothing much I can do. So in these cases, would you accept the fact that this patient will possibly go blind after a couple of years or 1 year and tell the patient, or you still fight till the end?
What a beautiful question. And my easy answer is I fight even if the eye is blind. So I have people that have blind eyes, for example, for neovascular glaucoma, and the pressure is high. I would put a tube in those rather than a cyclodiode to make sure that the shape of the eye remains normal. I will fight for a perception of light, bad projection. I'll fight till the end for everything, except if patient is, let's say, terminal in the intensive care units, and his doctors are telling me it's a few hours. I'm not going to take the patient in the OR to treat an eye if the life of the patient is ending. And the other thing that I will stop is if the patient asks me to stop. It rarely happened. And if the patient asks me to stop, I would give a vehement, passionate argument in favor of not giving up. But at the end of the day, I am not the boss of him or her, and we comply with what they say. Let me I'll tell you a story about doctors and different types of doctors. A long story, the story goes like that. A very famous general surgeon who plays tennis every day in his private club in a country in the Middle East has a trainer. And this trainer comes to him and says, you know, there's something in my right elbow. It is not very comfortable. So he takes him with him in the car. They go to his clinic. He does a small biopsy and he finds a terrible, very advanced sarcoma. So he tells the patient, now we have to amputate your right arm. And he says, impossible. I have nothing. This is my bread and butter. I work as a tennis trainer. I can't read. I can't write. I play tennis. Taking it out means that I will never be able to work and feed my children. So the general surgeon, very, very big and very wise, decides to tell him, well, okay, we'll give you some anesthesia to be able to, better examine the eye. And he takes the patient to the OR and amputates the arm and takes the arm and uses the thumb to put a fingerprint on the consent form. This is a true story, and I will leave it to your imagination and personal ethical code to tell yourself if this was right or wrong.
Sure. Dr. Mazen, do I still have time? I have a couple of questions. It's golden opportunity that Dr. Tariq is with us.
Of course.
I'm very keen.
Yeah. Till the morning.
Okay.
Mind you, my kids will kill me because of dinner. So I am not able to be. No, I would love to stay till the morning. It's just that the kids will probably amputate me. So
5 more minutes. Okay, I promise. So if I have a patient who has IOP pressure, let's say eye pressure of 10 all the time, and everything else is fine. I did phasing. Phasing is not showing any, spike above possibly 11. Field is definitely deteriorating. Age is, we are talking about 80 plus years old. MRI scan, blood, everything is fine. Blood pressure observation is fine. Is not going down in the evening and anything. So in these cases, if you do all the investigation, but you still have, the deterioration, would you trap the patient, or what would you do?
Would I operate, you mean?
Yeah.
Whenever you are out of resources, out of ideas for medical care, you operate. So you have looked for is IOP, it is always low. You have looked for all vascular effects and they're all negative. I would still operate, because even people with underlying vascular phenomena related to, sorry about that. Just have to turn off the phone. With vascular effects, we have seen that vascular properties of the optic nerve improve significantly after operations. So yes, I will operate them. Obviously, again, depending on them consenting, depending on them being in a decent health. I mean, I have people who are 85 coming with their own bicycles in Geneva. Those people obviously are having still a few years in their life, and they deserve to be very well cared for.
Perfect. And last thing, this is just a comment actually. For Paul tube, I don't know, that's my personal observation. I found it very easy to insert inside the eye, but the plate itself, it was very bulky. I found it slightly tricky because it's like silicone, kind of thick slightly.
It's very slippery.
Exactly. So do you think, I mean, stitching the plate on the sclera from in your hands, do you think it's kind of easier than Bervel's, or the same, or any tips for this?
It is more or less like a Bervelt. I use a 7.0 Proline.
Yeah.
So I use the needle, and I cut the stitch, the thread short. I asked the nurse, she knows that it's only for 2 stitches, so it's short. Otherwise, if it's long, it's going to be uncomfortable for you as you're tying. The needle is thick, but the Proline is also thick, which gives you a good anchoring of the tube. This is what I do. I don't know if I'm sure there are always different ways of doing things. Sometimes they're better than what we are doing, and that's why. That's why you have to come to ICGS, which is going to be in Geneva on the 23rd of February, because it's going to be 100% physical. Coming from the UK is quite easy. Coming from Canada is even easier. And Geneva in February will be a lot of fun.
Yeah, it's a pleasure. Thank you very much, Dr. Tariq.
Thank you. Thank you, Marie.
Okay, great. So very quickly, Dr. Tariq, I think we have 4 questions, 1 minute for each, please. Sure. Thank you for this wonderful session. My question is, do you do gonioscopy in the dark or not to detect the angle closure?
This obviously means that you have missed my first lecture for the Sinjab Academy, which was called The Dark Art of Gonioscopy. Yes, you cannot practice gonioscopy except in a dark room.
Good. Second, can we use the grayscale and visual field to detect progression, or should we use the comparison or probability measurements?
You have to use analysis, statistical analysis, like a trend analysis or event analysis. Grayscale is for you to show your patients. It's not for you to make a decision about if the patient has deteriorated or not. So trend analysis, event analysis, every single automated perimetry machine in the world has its own software. We just have to use it.
The OCT is a relatively new device. Can I ask you if the OCT changed your habits to diagnose, management, and monitoring of glaucoma?
It is not that new anymore. I think I used OCTs when I was a resident, and that was back in '94. So I wouldn't call it new. Has it changed my practice? Difficult to say, because I trained with an OCT as a resident. I always had OCTs in my life. It is a piece of the puzzle. It is not the most important piece, and it's not the only piece. But anything that can give you extra information, extra data, so that you can base your decision on it, is useful. I don't see it as a harmful tool. I see it as an absolutely useful tool. But anything should be used in moderation. You should not be ordering 10 OCTs per year, and you cannot also order an OCT every 2 years. So moderation and asking the right questions to be able to get correct answers.
Can you re-explain the relationship between capsulophimosis and cyclodialysis with hypertonic maculopathy?
The capsule actually, when the phimosis happened, it contracted, pulling on the ciliary body and detaching it. Once the ciliary body detached, it starts to reduce the production of aqueous, and at the same time, it opens the suprachoroidal space. Once the suprachoroidal space is opened, the filtration is much higher, and we end up having a hypotony. So cutting the capsule, the anterior capsule, and doing an anterior capsulotomy was the solution for reducing the traction on the ciliary body.
Perfect. Thank you very much. These are the questions. So we don't want to delay you anymore for your dinner, and happy appetite.
Thank you.
Jazakumullah khairan. It was wonderful, and نسأل الله سبحانه وتعالى أن يجعلها في ميزان حسناتك إن شاء الله، وميزان حسنات أيضا دكتور قديح، دكتور منير.
في ميزان حسناتك قبل أي حد دكتور مازن.
حبيبي أنا مجرد نحلة بس بنقل الرحيق من مكان لآخر بس.
And you know what they say about bees. If bees don't exist, the world will end.
سبحان الله. الله يجبر خاطرك. Thank you everybody for this session, and hope to see you next month with a new session as well. And please wait for us with the new series of that 2022, which will be more advanced, inshallah. Thank you very much, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much.
Bye bye, Munir. Assalamu alaikum.